Uh, my colleague Dr. Anirudh could not be here today, so I'll be presenting on his behalf. So continuing with the back to basics in uveitis, my friend he wanted to present the other side of it, that the multimodal imaging cannot be completely ruled out, or the advanced diagnostic techniques can't be completely ruled out, and they do make a slight difference. So with the background of the basic clinical examination and history taking, if this is superimposed on that, so you will be diagnosing the last 5% of the diagnosis which are elusive. I can't move the slide. So with this premise, the generally harbored thoughts are that imaging is not needed for the diagnosis of several conditions. Simple imaging tools in the clinic are usually sufficient for diagnosis and management. So with this in background, we'll look at a few cases and then understand how the multimodal imaging may help in the diagnosis. So a 17-year-old girl presented with sudden diminution of vision, right eye for 2 days, systemically well, and 2200 vision. So it is quite clear with headlight and fog appearance of the fundus that this is toxoplasma uveitis. Now on the FFA, we can see that it's a hypofluorescent lesion with surrounding hyperfluorescence, and OCT shows choroidal thickening, effacement of the all the layers of the retina with some amount of fluid surrounding the lesion. Now these are that was a classic case of toxoplasma retinochoroiditis. Now the case examples of typical features are in toxoplasma retinochoroiditis. They are retinal thickening and disruption of the retinal layers. There is a presence of choroidal hyporeflectivity. There are vitreous cells present. The hyaloid is thickened, as you can see in the bottom image with yellow arrows, and there is a disruption of ellipsoid myoid zone. So the key is to identify these lesions on OCT, which help in the diagnosis of toxoplasma chorioretinitis. Now, the key differentiating OCT features in toxoplasma are that there are clots of cells along posterior hyaloid, or clumping of cells along the posterior hyaloid, as can be seen as dot-like hyperreflectivity. There is presence of retrohyaloid hyperreflective spots, which are seen in the bottom image as white arrows. These are quite distinctive features of toxoplasmosis, and they are not seen in viral retinitis, because if we completely look at the OCT features of the chorioretinitis and look at only the retina, the features might appear similar in toxoplasma as well as viral retinitis. But these are the features which may help differentiate these two clinically similar entities. Now, the key differentiating features continued. As we see in this image, feature 3, it is the presence of hyperreflective oval deposits on the surface of retina. So these are basically clumping of cells present in the posterior cortical hyaloid, in the subhyaloid space, as well as on the surface of retina. Again, these often show mirror image deposits with the hyaloid. So this is basically clumping of cells in the subhyaloid space, and these are usually seen when there is a detachment of the hyaloid as the disease progresses. So there is a mirror image of deposits both in the undersurface of the cortical hyaloid and which are mirrored on the surface of the retina. So these are features which differentiate toxoplasma chorioretinitis from viral retinitis. Now, choroid is displays major features of toxoplasmosis. Toxoplasmosis is an infection which begins in the nerve fiber layer in the retina and then progresses to involve the choroid also. So there is a disruption of the choroidal architecture. There is thickening of the choroid with loss of architecture of choriocapillaris, and choroidal vessels are not usually visible. EDI OCT, it reveals a full thickness choroidal granuloma. Now this is moving on to another entity of choroiditis. So in this, we'll discuss the features of EDI OCT, Enhanced Depth Imaging OCT, and it reveals the presence of full thickness choroidal granuloma. This patient showed calcified mediastinal lymph nodes, and on EBUS, it was positive for Mycobacterium tuberculosis on PCR. So now these findings are quite common. However, how do we differentiate them from other similar entities? So in EDI OCT, in case of tubercular choroiditis with choroidal granuloma, EDI OCT helps us to monitor therapy. So as this has been published, EDI OCT is extremely useful in the follow-up, in the sense that these lesions heal entero-posteriorly first, followed by lateral shrinking. So as you can see, the images are correlated with the fundus picture also. This is another case of intraocular tuberculosis, and this is a case of subretinal abscess, tubercular abscess, and this is a simple fundus photograph, and based on this image and what we see on indirect ophthalmoscopy, we might miss out on a lot of things. So this is a simple fundus photograph. However, if we do a fundus fluorescein angiogram, there is so much more that is revealed in the vasculature. We can see there is a presence of peripheral vasculitis, and there is a RAP lesion which is present at the macula. So these findings are very, very important, and they help us manage the patient in a better way. So this is the same. Now this is another case of retinal vasculitis with areas of capillary non-perfusion, NCME. This patient was positive with MON2 and CECT chest was positive. So this imaging technique, wide field, ultra wide field imaging technique, helped us delineate the peripheral avascular ischemic areas which would otherwise be missed on clinical examination or with routine fundus photography. However, this could be visualized on ultra wide field, and selective treatment of the ischemic areas was done. So similarly, white dot syndromes can also be diagnosed and managed using multimodal imaging. So this is a case of serpiginous choroiditis, and here this is a FFA plus ICG image which shows the capillary the low flow lesions of the choroid on ICG, which would otherwise not be visible on simple FFA. So here the capillary, the low flow areas or no flow areas on the ICG scan are seen when compared to FFA, and you can see the extent of low flow lesions as vis-a-vis the fundus fluorescein angiogram. So there is choriocapillaritis, there is inner ischemia, flow deficits in the choriocapillaris slab. It corresponds to ICG, but in a more clear manner. So these have been published by the presenting author. So this is baseline, and this is after 3 months. We can see that the flow deficit areas have completely, the flow has been restored, barring a very few persistent defects after treatment. The same thing is highlighted very clearly on the angioflow. So the healing of the lesion is accompanied by reduction in the choriocapillaris flow deficit area, and lesions which are less than 0.1 millimeter square, they tend to resolve with minimal flow voids. So this is the advantage of fundus fluorescein angiography, ICG angiography, and OCT angiography in case of white dot syndromes, and how they help us monitor the disease and manage until the exact end point of the disease. This is similar. Thank you so much. So in the interest of time.